So the large core trials, meaning large ischemic core with large vessel occlusion, were a big headline at the International Stroke Conference. Both the ANGEL-ASPECT and the SELECT2 randomized trials reported, and both were positive in favor of thrombectomy for patients with large ischemic core, i.e. aspects of 3 to 5 and volumes of 50 to 100 cc's, depending on which study you read. And so that will be definitely practice changing. Thinking in the background that there are still about 3 additional trials that need to report. So what is going to happen with these 3 additional trials that haven't finished reporting is very interesting. Will they continue enrollment? Will they stop? These are all questions that are all on our minds. And then what do we do now? In the interim, we have now 3 positive trials. The first one, MRI-based from Rescue Japan, also reported at the ISC last year, and now 2 additional trials on large ischemic core with ANGEL-ASPECT and SELECT. So those will definitely change practice and widen the number of patients who are potentially eligible for thrombectomy. It will also decrease the rigor by which we select patients with good-looking aspects, or it will decrease the rigor of the need to do advanced imaging that has been so heavily announced or so heavily advocated for in the late window. So I've been writing about this quite a bit, and many guidelines have been stating that you need to do this CT perfusion and MRI in the late window to select your patients. But now that we have large core going out to 24 hours, this evidence, we may not need to be so selective because most patients seem to benefit if they have a large vessel occlusion and a relatively good-looking CAT scan. So it may allow us to rely less on advanced imaging and just goes to the interventional suite if you have a prospective patient. The other big news was, I think, the dual antiplatelet therapy is big news. It has not been published yet, so we still wait for that to be finalized before changing practice. But certainly it gives the clinician some flexibility in thinking about dual antiplatelet therapy in a patient who's borderline candidate for intravenous thrombolysis. And then more data came out on Tenecteplase being non-inferior to Alteplase from a trial in China, led by our colleagues, I believe, in Beijing. And then another trial led by Professor Liping Liu about blood pressure. When do you initiate blood pressure lowering measures in a patient with an ischemic stroke? Randomized 4,000 patients, unbelievable, and found no major difference between early versus later blood pressure. So I think these were very important trials. And Professor Dr. Eva Mestri from Cincinnati also reported data from the BEST-2 trial about blood pressure lowering. And I think we need to still tailor some of our management towards the optimal range for these patients and not go too aggressively lower because there might be a signal of harm. And that also validates from the ENCHANTED-2 trial that was reported at the WSO showing harm at the 120 or less range. So Dr. Mistri's work is very important in adding to this literature of not being too aggressive on lowering blood pressure after thrombectomy.